Joining me now is Dr. Deborah Boland, a neurologist locally that is going to help us with a disease that a lot of people have, but a lot of people don't understand. So when we look at epilepsy, we're looking at individuals that have problems, and it's not a motion problem, actually it's the connection from the brain to the body itself, and it goes a little haywire. And so we have a lot of people that look at these individuals and say they're kind of odd, but actually it's a very common problem. So let's go backwards a little bit. Epilepsy, well, what's it mean? And then going down, breaking down the different types of seizure disorders that are out there.
Okay. So a seizure is abnormal brain activity, and when the brain misfires. Epilepsy is a syndrome normally. When someone's had multiple seizures, they'll then get the diagnosis of epilepsy. There can be provoked seizures or unprovoked seizures. Provoked seizures, as we know, the reason and the cause for them. So one of the most common provoked seizures is an alcohol withdrawal seizure. So someone who drinks a lot of alcohol might have an alcohol withdrawal seizure. But you could have a seizure because of an infection. Kids, a lot of times if they have a high fever, will get a seizure. If you have high or low blood sugar, if you have low sodium, that can cause a seizure. Medications can cause a seizure, both prescription medications that will lower some people's seizure threshold, or non-prescription medications like drugs of abuse can cause that.
Sure. Now, when we look at the different types of seizures, we have causes, obviously. When we start looking at syndromes and different pieces so we can categorize them. When we categorize them, we're looking at the diagnosis, the type of seizure that it is, and then we're able to start treatment for those. But you touched on something I want to touch on real quick. When the kids have seizures, it's early on, and they're not going to be epileptic later on, correct?
It depends on the seizure type. So some of those children will outgrow those seizures. One is, the old name was Rolandic seizures or Beck's syndrome. Sometimes those kids can outgrow those kind of generalized seizures. Other times, if it's a significant genetic cause with other neurologic and physical manifestations, and they may not outgrow them, and they may be difficult to control. So there's a full spectrum of easily controlled seizures that children will outgrow to, unfortunately, seizures they may not outgrow. So it's very dependent on the cause. So prognosis is always dependent on the cause of the seizure.
So we go back to the categorization pieces and causes again. It's obviously parents going to be very interested if their child has a seizure, and if it's a febrile seizure, they're always worried, is it going to happen further on as they get older? So let's break down the seizures for us. So a lot of these, they seem to make sense, but until you haven't seen one, so, and you've seen a few, I would imagine. So break these down for us to get a general onset wise, and then we'll go into absence and the other different ones.
Okay, so a lot of times, a generalized seizure, that means that it's both sides of the brain are firing, versus a focal seizure where just one side of the brain is firing and too much electrical activity. So a generalized seizure might start with some head turning, or it can just start even with both arms jerking, or both legs jerking, or both arms stiffening, or both legs stiffening up. Typically in a generalized seizure, because it's involving both parts of the brain, the patient will become unconscious. When it's involving one side of the brain, the patient could become unconscious, or they may maintain consciousness throughout the seizure, depending on the kind of, we call those focal seizures.
So obviously the brain is the thing that controls the body, and the seizures is the brain acting offline or not correct, but then it sends these symptoms out, and the body does whatever little dance or pieces that we see. So it's, when you talk brain, obviously you're a neurologist, most people aren't going to see the brain fire, they're going to see the body's reaction to it. So, and that kind of grabs people's attention really quickly. When someone's having a generalized seizure, safest thing to do for them is?
So the safest thing to do is stay with the patient. Don't run and call 911 right away. So stay with them, keep them safe, make sure they don't have any bodily injury. Don't put things in their mouth. I think that was an old wives' tale that people thought, but definitely do not do that. Do not give them anything to eat or drink. If you can, time the seizure. That can be hard to do, but time the seizure, stay calm, be sensitive, supportive. And then if you think this is a first-time seizure, that would be when you would call 911. Or if the seizure lasts longer than 5 minutes, or if the patient injured themselves.
Sure. Now, getting them to the ground, making them comfortable, making sure that there's nothing around them. People really don't die from seizures, right? I mean, it certainly has some issues where they can advance into it, but an average seizure, it's really more of a offline then comes back on.
Absolutely correct. Most people do not die from a seizure, and the seizure will be short-lived. If the seizure persists, That's what we call status epilepticus. And if that is not eventually treated, then you would die from that. But that's when we need to get you medical care. And most of those status epilepticus patients are in the ICU to treat that.
And that's a challenging environment to be.
Yes.
So we look at this individual, they have the symptoms, we make them safe, and then we say, hey, this person has a seizure, first time onset. We bring them to a neurologist. The neurologist says, what happened?
Correct.
And in that time period, everybody's freaking out.
Right.
And it's the longest couple of seconds of your life that you
Right.
have that. So what do we do next? You know, treatment-wise is probably the hardest part about this.
Right. So we always want to determine the cause with seizures. So we like to do a brain MRI. Regardless of the age, typically, we'll do an EEG, and that's probably the most important test, and that's looking at the electrical brain activities. And a lot of times those generalized seizure patterns we will easily pick up on an EEG, even if they're not seizing. So we like to do an EEG, and we always do lab work too to see if we can find a provoked cause.
Sure.
So we do the workup. If we determine the cause, then we go from there and we determine the best medication once we determine the cause, because different medications work for different causes.
Sure, and the medicines obviously have to be taken all the time.
Correct.
They have to get up to a level. If we skip it or we have other problems, or medicines can interact with them as well. So this is a complex issue when you talked about medications. So they're always looking for shortcuts. So I don't want to take medicines. What else is available to me?
No shortcuts with epilepsy and seizures, unfortunately. Medications is your first line, and sometimes we even have to use multiple medications, perhaps maybe two, and neurologists like to call them anti-epileptic drugs, or AEDs, so that's an acronym that people may have heard before. And if we get past two and that's not controlling our seizures, then we look at other alternative options, things like VNS, vagal nerve stimulator, or if there's a focal seizure with an actual area of seizure focus within the brain, and it's not an area that would cause significant deficits, we can remove that tiny little area of the brain surgically, and a neurosurgeon would do that. Another thing we can do is what's called RNS, and that's responsive neurostimulation. And we stick electrodes in the brain, and when that area of the brain is going to seize, they'll provide electrical stimulation to it and can stop the seizure.
So there's a lot of options.
There's many options, yes.
And even though you have these seizures, you can live with them. We were talking about balance before.
Yes.
We don't have a whole lot of time, but that balance piece is probably the biggest piece you want to get across. Is that it's a disease that we have, but it's a treatment, but you live with it. It's lifelong.
Correct. And I think having a balanced, healthy lifestyle is the most important thing. Picking a great team of physicians who understands the disease, is willing to manage. I always tell my patients, keep an adequate medication list, up to date, accurate, and make sure that you have the medications you've tried that have failed, and make sure you have any allergies listed on there. I like my epilepsy patients to wear a bracelet to say that they have epilepsy. Let your community know, friends and family, that you have epilepsy, so they know how to help you. So all of those preventative measures are the most important things.
Absolutely, because it's all about safety when we have it. We can't stop it at that point, but we make them safe, and then we can deal with the future ones and hopefully prevent.
Correct.
Great information. Obviously, November is National Epilepsy Month. This information needs to go out because we tend to shy away from these individuals as opposed to go in and help. Everybody wants to get their camera out and take pictures, but not really jump in and help. So this is not something that you should watch from a distance. You should get up and help with. So thank you so much for joining us today. Thank you for bringing this information, and we'll hopefully see less problems with it and more people understanding.
Great. Thank you for having me.